Thank you. We are reconvening this morning's budget testimony for the FY24 budget. This afternoon, we will be hearing from Behavioral Health, Health Department, and Office of Homeless Services. And to start off our testimony today, Mr. McDermott, who we have first up to testify?
Dr. Jill Bowen, Department of Behavioral Health.
Thank you. Good afternoon. Dr. Bowen, you're on.
Good afternoon, President Clark and members of City Council. I am Dr. Jill Bowen, Commissioner of the Department of Behavioral Health and Intellectual Disability Services, DBHIDS. Joining me today are Dr. Tiara Pritchett, Deputy Commissioner, who oversees the Division of Administration, Finance, and Quality, and Dr. Sosunmulo Shoyinka, Chief Medical Officer for DBHIDS. I am pleased to provide testimony for the Department of Behavioral Health and Intellectual Disability Services Fiscal Year 2024 budget. The Department of Behavioral Health and Intellectual Disability Services envisions a Philadelphia where every individual can achieve health, well-being, and self-determination. The mission of DBHIDS is to educate, strengthen, and serve individuals and communities so that all Philadelphians can thrive. The Department of Behavioral Health and Intellectual Disability Services oversees a network of nearly 200 providers and community-based organizations who are responsible for serving children, youth, adults, and families in Philadelphia with behavioral health challenges and/or intellectual disabilities, and acts as a safety net for the people of Philadelphia. DBHIDS makes every effort to ensure Philadelphians have access to treatment, supports, and services. Philadelphians are impacted by multiple layers of trauma. Those traumas result from a range of circumstances, including violence, poverty, the substance use crisis, and larger societal contexts such as current and historical racism, political unrest, and the lingering impacts of the pandemic. The pandemic highlighted pre-existing health disparities, particularly in Black and Brown communities, and we saw how much more we need to do to ensure equal access and culturally competent services for all Philadelphians. Often, it's the lack of adequate housing, food, and economic opportunities, the social determinants and drivers of health that contribute to the behavioral health challenges people we serve experience. We also know that depression, anxiety, and suicidal ideation are all on the rise, and we track the demand for the multitude of services we provide. These challenges are complex and are often interconnected. When I became commissioner a little over 2 years ago, I set forth the department's priorities to address trauma, achieve equity, and engage community, what we call TEC, T-E-C, as the vision through which we align all of our work. In doing this, we are implementing approaches to transform our system, looking at existing policies and practices, working closely with community to ensure alignment with tech, as together we work through a recommendations to action approach with the goal to transform operations to be trauma responsive, trauma informed, and trauma mitigating, and transform systems to reduce behavioral health disparities and promote racial equity amongst BIPOC communities, and to transform systems to engage, empower, and integrate community, including the wisdom of the community into program development and operations at every level of our work. We support a multitude of trauma-focused programs that address trauma at the individual and community levels through multiple modalities. In 2022, we launched an external stakeholder learning collaborative that convenes over 100 stakeholders, which includes people with lived experience, families with lived experience, scholars, community-based organizations, providers, advocates, and others from the community who set forth recommendations that DBHIDS has begun implementing and will continue to implement over the next 24 months. The subcommittees of this body engage in a thoughtful conversation around how to integrate fragmented programs into a systemic whole, how to make it easier for people to access information about those programs and to better understand how they flow together as a systemic response. Critical to this work is to ensure social determinants of health are a significant part of the efforts to address the multiple layers of trauma faced by Philadelphians every day. The 5 subcommittees out of which the recommendations to action arise are traumas related to violence, traumas related to children and families, prolonged trauma, trauma related to secondary stress, and defragging the system or decreasing silos. These recommendations to action have been developed into a comprehensive trauma response plan. Through the committees and our boots on the ground work, we have created and distributed over 30,000 trauma cards door to door for adults and for children. They have been distributed at public libraries and health centers through the help of City Council, through Play Streets and online. We have produced public service announcements through radio, television, posted on newsstands throughout the city, and at music venues to get the word out to all Philadelphians that behavioral health crisis services are available and accessible to everyone through 988. We hosted our inaugural tech conference on March 24th with over 400 participants. The tech conference highlighted the amazing work of thought leaders from community-based organizations across the city, focusing on trauma, emphasizing equity and service delivery for all Philadelphians, and ensuring that in every aspect of our work, we are engaging community voices. This conference serves as a kickoff to continue these conversations within neighborhoods through roundtable discussions now being planned. With awareness and great concern that we are only seeing the tip of the iceberg, our children are struggling. As a result, DBHIDS has structured a reboot of the Children's Behavioral Health Cabinet. Priority areas have been identified in each of 3 tiers: prevention, early intervention, and treatment. Tier 1, social media impact on children's mental health. Tier 2, enhancement of STEP, or the Support Team for Educational Partnership, to expand to all schools. Expansion of DBT, which is dialectical behavioral therapy, a form of cognitive behavioral therapy that helps in the development of healthy ways to cope with stress and has been helpful for those struggling with intense emotions. The focus areas of these subcommittees, incorporating the successful recommendations to action approach of the External Stakeholders Learning Collaborative, is to move this work to implementation as quickly as possible. With the support of City Council, we have significantly expanded the Philadelphia Crisis Line and built 24/7 regionalized community mobile crisis response teams that are the Philadelphia model and is preliminarily reflecting positive outcomes. We are monitoring, working with the providers, and have posted these outcomes publicly at dbhids.org/988. We are continuing to develop this website with feedback from the community. The media coverage about the model has been quite positive. The Crisis 2.0 framework includes an array of crisis services aimed at providing immediate crisis stabilization, de-escalation, and behavioral health assessments that acknowledge and address social determinants of health, as well as crisis resolution within the community. Philadelphia was lauded as a model city for 988 by the Biden administration, whose senior federal and state leaders came to Philadelphia for the 988 kickoff in summer of 2022. We have just stood up the first crisis intervention support team aimed at providing up to 6 weeks of continuing support for those whose crises are more challenging, with a goal of preventing reemergence of the crisis, and continue to develop our technology platform, Care Traffic Control. Additionally, a 5th Crisis Response Center, or CRC, expansion in West Philadelphia is due to open this summer, 2023, and the procurement of the first adult behavioral health urgent care center is in development. DBHIDS will continue to be a solution-focused, trusted partner and safety net for the city of Philadelphia. The goal is to create a Philadelphia model that aligns with the priorities of tech, reducing systemic trauma, creating greater equity, and fully engaging the community. DBHIDS aims to blanket the city with trauma supports in an effort to alleviate the many ways that chronic trauma is manifesting itself as a response to gun violence, the pandemic, and a variety of social determinants of behavioral health, including trauma from generations of systemic racism and discrimination. Some of the examples of this approach includes the network of neighbors, composed of community members trained to support and lead responses to stress, trauma, loss, violence within their own communities. Through our Engaging Males of Color initiative, DBHIDS developed the film Trigger in collaboration with First Person Arts. Trigger is a highly powerful film that focuses on the personal stories of people in Philadelphia impacted by the trauma of gun violence. DBHIDS has sponsored several screenings of Trigger at various locations throughout the city and will have more scheduled across communities throughout the year. We will be issuing invitations shortly for members of City Council to join us at a screening. The screenings include a talkback and panel discussion, and behavioral health professionals, resources, and supports are on site for those needing assistance during the screening and to connect to ongoing supports. The film has so far reached well over 700 people, and we expect that reach to be over 1,200 by the end of fiscal year 23. DBHIDS's efforts to blanket the city with trauma supports include increased efforts in developing and implementing innovative strategies to address substance use disorder in Philadelphia. Substance use is a crisis in Philadelphia, with rising overdose death rates and traumatic experiences for those with substance use disorder, as well as for community members. DBHIDS works closely with city partners and external stakeholders in responding to the substance use crisis by expanding warm handoffs to resources and recovery supports, expanding medication-assisted treatment, expanding on-the-ground assessments, increasing residential bed capacity, increasing ASAM Level 4 complex care capacity with innovative approaches to the integration of wound care and substance use rehabilitation, especially in light of the horrific wounds being experienced from xylazine, which has been increasingly present in the drug supply. DBHIDS has helped to stand up the first licensed wound care van in the Commonwealth and is developing a procurement for the first mobile methadone van in Philadelphia. Mobile units are intended to engage people where they are, provide assessment and treatment, and encourage people to come in for treatment and services as they work to ultimately achieve long-term recovery. DBHIDS is committed to the behavioral health and wellness of all Philadelphians, from innovative programs in early intervention through exciting new models in addressing the physical and behavioral health of seniors, to the integration of mental health and intellectual disability services through whole person care for those with both mental health and intellectual disability challenges. We appreciate the ongoing support of Council and the opportunity to highlight the work of DBHIDS. My colleagues and I are happy to respond to questions at this time. Thank you.
Thank you, Doctor. Thank you very much. Just have a couple of questions, budget related. In your FY24 budget, you show 84 of 345 budgeted positions as vacant, comparable to some degree to pretty much all of the city departments. Can you tell us how that level of vacancy has impacted your ability to do your work and what you're doing to potentially fill that gap?
You know, we are looking very strategically at the positions and working to see how we can expand some positions and reduce other positions to be as efficient as possible, but also to prioritize. Everything that we do now aligns with the vision of tech. So we are being really strategic about which positions we need to prioritize, shifting over some funding to create positions that are more marketable, especially in the high priority areas, and to try to do as much outreach as possible to encourage people to come and work for us. The same problem exists with our provider network. So some of the strategies that we have incorporated internally, we're also incorporating externally. There's a whole array of approaches that we're taking, everything from producing a video that is why I do this work, to try to encourage people to either stay in the current positions or be attracted to coming in. We set up the first practicum, clinical practicum connector, and what we did was we brought different programs with the students or the interns who were in social work positions, for example, which is one of our most critical positions. And we introduced the students to the idea of working in public behavioral health. And if they get the bug, the goal is to have them not just step in and be helpful by filling positions while they're in a training, whether they're fellowships or internships, but also to then retain the goal is to retain those folks. We've looked at different positions that are particularly at risk, and we looked at whether they were being supported in terms of their educational goals. So by looking at recruitment and trying to reach out in ways that we had not reached out before. By the way, our folks who move on, we haven't had a lot of people just leave. We've had people retire, and we've had people take advancement. And many of the people who advance from DBHIDS stay within the city system. So we struggle like everybody else, but we also are very happy when people are succeeding and moving forward for those reasons and not just kind of stepping out of the field. And then we are really looking at next gen to really try to encourage folks to come in and look for those innovative ways to connect up with current schools, like social work schools, nursing schools, et cetera, to try to encourage them to come in now, as I say, that in a way that would be helpful. With the provider network, we're looking also at a systemic sort of approach to a business, to think in terms of business and how working as a system and sharing some of the ways in which people can access the services might be able to help alleviate some of the challenges around the vacancies.
Okay. You referenced the colleges and universities. I mean, shouldn't that be a significant feeder system to?
So it's really interesting. So it tends to be a significant feeder, but we also are trying to attract people. First, we want to make sure that people are still attracted to it, that have in the past been attracted to it. But we also want to attract people who would not think that, oh, when I grow up, I want to be in public behavioral health. And sometimes that is a minority population. We also want to think of what the barriers are to coming in for internship as well. So we're looking to provide stipends and support for people to come in. It's for some people, it's very hard to do a training and also hold down the job and also, have other responsibilities. So depending on what your circumstances are, we're trying to make it as easy as possible and bring down any barriers to coming in terms of training approaches.
All right. Well, I didn't grow up thinking I'd be a politician, but I ended up being one. So I understand that. Question with respect to the performance measures listed in your testimony, employer participation in wellness activity. In FY22, you had like 576, and this year is dropping target less than 250.
I can think of a couple of different reasons for that. One is that a lot of that was virtual last year, so you have a lot more participants because everybody can just get on, right? And this year we've been trying to do some more in-person experiences. So I think that probably accounts for most of it. We do have a wellness unit embedded in DBHIDS, and they do a lot of really interesting approaches. Also, our diversity, equity, and inclusion does a lot of engagement as well. So just some of the possible, reasons for that. Also, we do a wellness newsletter and we do a wellness week, and so I think people are getting a lot of that wellness activity in a couple of different ways. So I wasn't particularly concerned about that, but you see that with a lot of the virtual trainings we've done it as well. Once we start to go back, you're going, and we've thought about that, so we're trying to be hybrid with our approaches.
Okay, my last question. Pre-pandemic, there was this discussion about, to some degree, merging some of the activities that the city of Philadelphia had, that the school district actually had. It was somewhat redundant in terms of some of the services we provided for children and families, and similarly on the school district. And I believe there was a conversation of the city of Philadelphia providing those services, forming a partnership with the Philadelphia School District to both be more efficient, but more importantly, to save money. Like, why do we have two entities providing a similar level of support, particularly around trauma-related activities, given what's been going on? What's the relationship with the Philadelphia School District and the children and the families, particularly around trauma-related activities?
So there is a tremendous amount of work that DBHIDS does with the school district. It's absolutely a partnership. I've sat down with Dr. Watlington. I mean, this is a real collaboration in terms of the kind of work. It's absolutely necessary. You heard me speak in my testimony about the kids being in crisis, and they absolutely are. So it's not really about, I think, duplicative. I think it's different. The work that we do is we are embedded in the schools for a tier 3. The IBHS, the Intensive Behavioral Health Services, is something different than what the school district actually provides. And it's for the kids that are identified in the school as really struggling and needing that tier 3 or that kind of intensive treatment approach, but having it available in the schools. That approach is also one that's in the communities. So it's community, school and home approach, primarily in the schools. And there's a lot of training that's going on to make sure that the treatment, the evidence-based treatment, is trauma-focused, specifically trauma-focused CBT, which is, the gold standard. So that is not something that's duplicated by the supportive work that the school district does. The school district does have capacity to provide behavioral health supports, especially at the tier 1 universal level and to some degree at the tier 2 level. STEP is a perfect example of a sort of a partnership between DBHIDS. That program is a tier 2 program. It's in 21 schools right now. In testimony, I also mentioned the desire to bring that up to every school. We helped develop it together with the school district, and it is actually the school district for the first time is actually a provider. And the people that they've hired to do that in those 21 schools can bill for those services. This is the first year that billing has been possible. They've gotten licensed and they bill community behavioral health. So they essentially have this ongoing relationship and they now have a sustainable source of funding. We, with the help of the state, provided the last few years of funding to stand it up. Now that it's stood up and billable, that's just the perfect way to create models, make sure they're effective and scale them up. So this is a really good example of that. So I would call the relationship between DBHIDS and the school district more of a collaboration and partnership than sort of an overlapping of services.
Okay, thank you. Chair recognizes Councilwoman Gaudier.
Thank you, Council President, and good afternoon, Dr. Bowen.
Hi, how are you?
I'm well. I want to start by thanking you and your team for just the critical work that you do. It is absolutely vital for the health of our city. I have some questions about mobile crisis units. Last year, you anticipated full implementation of community mobile crisis response teams by the end of 2022, with the 4 providers operating between 15 to 20 teams across the region and across the day, evening, overnight, and weekend shifts. Was this accomplished?
Mostly it was accomplished. We feel very, very good about what we've accomplished. We are 24/7. We do have 4 providers active. 2 of them are fully staffed. I think this is what you're getting. 2 of them are fully staffed 24/7 round the clock. It's actually, we have 3 teams and a bridge team. One of them is the third one is mostly 24/7. They have a couple of challenges around like weekend evenings. And the other one is still pretty active, but has a few more holes in some of the harder to fill time slots, which might be weekend. But we can cover the whole city. Because we are centrally dispatching through the Philadelphia crisis line, if calls come in, we are able to provide 24/7 citywide, regardless of whether it's in the region. So we are working to get to that, but we have 100% stood up the Philadelphia model of the community mobile crisis response team.
That's wonderful, and thank you so much for that. Can you just clarify how many teams we have operating altogether?
So it's 4 per provider.
Okay.
Right. So it's like 4 times 4 is like 16, and you'll have a couple of holes in there. So it's probably more like 14, while the other teams, get finalized. And they're working very, very hard to fill those positions. And they've actually had a fair amount of success, I have to say, considering the I mean, people want to do this. I think it's innovative, it's exciting, and they're interested in doing it. And we did, if you haven't seen the Inquirer article where the journalists went out with the Community Mobile Crisis Team, did a ride along, it was incredible because what they experienced was when we talk about the Philadelphia model, we mean having people who are members of the community or really are familiar with the community that they're serving. And what happened along that ride was an individual who was in distress, and the members of the response, the CMCRT, were able to say, oh, look, we're passing by the high school I went to, or hey, I go to that church, and the person immediately calmed down and engaged, and it happened in front of the journalist, and I said, this is working.
Thank you so much. That is incredible progress and incredible work. I'm going to tick through my next question so that I don't run against time. So next, do you have any information about the outcomes of both the co-responder teams and the mobile crisis teams? What efforts have we made to raise public awareness of the availability of non-police mobile crisis units, and how do we know those efforts are working? And lastly, how many calls were shifted to the Philadelphia crisis line from 911 in 2021 and 2022?
Okay, so I have all of this data. Just give me a second to find it in all of my stuff. Okay, so let me grab what I've got first here. So from January 2022 to February 2023, 983 calls were shifted from 911 to 988. But it's actually underrepresenting because we now have Philadelphia Crisis Line workers embedded at 911. They are actually in the 911 radio room. So in addition to the calls that we're checking here, the 983, what happens in that room in real time is that the Philadelphia Crisis Line workers can take those calls and kind of ship them in real time. So we're working to try and get that information onto our spreadsheet, right? And as I said,
if you could follow up with the calls diverted, but also how many calls were handled in the 911 call center, that's pretty valuable. Thank you.
Right, it's really valuable. We're also tracking, so community engagement is one of our, requirements. And just let me pull this up quickly. So I give you the exact number, but by far 80% of the calls are either resolved in the community, that's 64% of them, or voluntary evaluation, that's 16% of them. And that was one of our real, goals. And then we have done some satisfaction surveys, and we have found that 72% of responders strongly agreed that between consumer survey that it was helpful. Okay, I'll just get this right. That 72% of respondents strongly agreed, and another 4.5% somewhat agreed. So if you put that together, that the mobile crisis team was helpful and informative. Also, 78% said that the response time was, had met their needs, but we have a problem with the response time. I'll talk to you about that in a minute. And then 75% of participants rated their overall satisfaction with services that were provided as a 5 out of 5. So satisfaction by the people receiving, and also that their information, that they got the information that they needed and they got help. These are also, along with resolving in the community, are some of our goals. As far as making sure that people know about it, in addition to the information I just gave you, it is available at dbhids.org/988 to make it transparent for people to be able to see this data themselves. And we're actually making a better web page that's even nicer. This is just, we wanted to get it out and up as much as quickly as possible. Also, 988, I've done 2 PSAs, one through ABC, another one through NBC. The ABC one is running. The NBC one will be running soon. We also have posters up at newsstands around the city. We have up, we've done several radio interviews. We've done traffic and weather together, brought to you by DBHIDS, about 988. So we've done quite a bit of effort to get the word out. In addition, we have hired Little Giant with the help of Scattergood, and they are doing a neighborhood by neighborhood by neighborhood focus group work so that the messaging is done in a way that's most best received by the people in different neighborhoods, because we know not everybody processes in the same way, not everybody speaks the same language. All of those things are critically important so that everybody really gets the message.
And have we seen a correlation between the advertising and the engagement that we're doing and a knowledge in the community that mobile crisis units are available to them? And then could you touch on the response time issue?
Okay, so we don't have that feedback yet because we're just running the PSAs and getting the things out. So we will have to, get that information about how people responding to that. Although I get a lot of comments like, "Oh, I saw that. That was good." That that kind of thing. The response time, our goal is 30 minutes. In the field, that's the best that's been seen, but we want the best for Philadelphia. So we understand that's not easy, but we also understand that we are a little over an hour now. So it was an hour, I think it's been an hour and 8 minutes. Now it's an hour and 7. So it's a little bit over what is okay for us as far as we're concerned for Philadelphia. And so that is presenting a little bit of a challenge for us, especially during the higher, volume times.
And what's the plan to sort of reduce those response times?
Yeah, so, we have thought about putting additional bridge teams on during those difficult times. We would need funding for that. We've looked at things like how long does it take to get somewhere? How much is it when a team has to go to a different region? Is that throwing it off? So we don't have a set answer yet, but we do think it has to do with the particular times when it's highest volume.
Thank you so much. I may come back around on the second round.
Okay, thank you.
Thanks, Council President.
Thank you, Councilwoman. Chair recognizes Councilman Harity.
Hello, Council President. Hello, colleagues. Hello, Commissioner Bowden. My questions are actually for the Health Commissioner, Commissioner Bedegal, if that's possible.
Commissioner, you on?
I am here.
Sure. Go ahead, Councilman.
Although I'm also scheduled next, so I don't know how you would like to do this.
We'll jump in. We've been the rules. We've been the rules every now and then.
I only have a quick couple of questions and get you out. So what I'd like to know is is there a plan for the areas that are most affected by the opioid crisis, like Kensington and South Philadelphia? Does that plan include safe injection sites? And did you sign a letter or a court document in favor of safe injection sites for the challenge that's going on right now?
So the plan for dealing with opioid overdoses as well as other types of overdoses is really citywide. We are focusing both on, Kensington, also on South Philly, but increasingly on North and West Philly, where we're seeing rising levels of overdose deaths. And we're doing a combination. We are trying to get information to people so that they understand that fentanyl and xylazine are in many of our drugs at this point, trying to get fentanyl test strips and xylazine test strips out to people so that they can take action to protect themselves. Part of the problem is that many people who use stimulants may not realize that those stimulants can have fentanyl in them. And so a lot of people are dying of an overdose. We think not necessarily anticipating that they would be taking fentanyl. So we're also working on best practices for xylazine withdrawal, because that's something that's stopping a lot of people from seeking treatment. They're afraid of the withdrawal symptoms, and so they stay away from treatment programs. I've lost your second question. I'm sorry.
My second question was, does the plan include safe injection sites? And the third question was, did you sign a letter in support of safe injection sites for the current legal process that's going on now?
If I could jump in, Councilman, Eva Gladstein, First Deputy Managing Director. The City of Philadelphia did file amicus briefs previously on behalf of both the mayor and the health commissioner. That process was prior to this health commissioner. I'm not sure if this health commission was included in, I think we filed twice. And I know you did previously talk to the city solicitor so they could provide more information, because they filed on behalf of the mayor and the health commissioner at that time. With regard to plans for overdose prevention centers, I think you're aware, as we've read in the newspaper, that there's a mediation process going forward, and the city has been clear that we would not establish any without there being a legal pathway to establish those. And I know that council members previously had concerns about their role if that were to occur. And I will just say that we would certainly, if there was a legal pathway established, first of all, we don't know if that will happen. Secondly, if it were to happen, we don't know when, but we would certainly consult with council members, particularly district council members, in terms of citing, community engagement, how to meet with residents, what the concerns were, and how to mitigate any concerns. But we are not at that point in this process at all.
Okay. But you are supporting efforts to bring safe injection sites to Philadelphia. Is that correct?
We have stated our support for a number of years now, and we've also stated that we would not support anything that did not have a legal pathway. That is correct.
What about a community pathway? What do we do about our residents who are anxiously waiting an announcement on what you guys are going to do? I mean, to me, safe injection sites basically is that we're throwing our hands up and saying, you know what? We don't know what to do. Go ahead, shoot up, whatever. We're going to just make sure you don't die. I'm just trying to figure out how you guys could come out in support of something of that magnitude without consulting us in the legislature, and also without having buy-in from the communities, which it's going to affect. I think you guys got an idea and you're running with it, but for me, it just seems like you're giving up. Treatment has always got to be the first and most important thing, because just because they're being kept alive does not mean they have a life, does not mean they're going to be a part of society. And what the main goal has got to be to get these poor people into recovery so that they can actually have a life. And I'm very upset. I'm very angry that you guys are trying to go around us and go around the community and just do whatever you guys want. And now that I know that the mayor's in on it too, that just makes it that more upsetting for me.
Councilman, if I could, I hear your I hear what you're saying. I want to say that we all agree that helping people get into treatment and recovery, which is often a very cyclical process, is our highest priority. It is not just about keeping people alive, but it is helping them stay alive and access services and treatment, however they may be able to connect with it. This is something that the city has researched pretty extensively.
Yeah,
We
so have I.
visited.
Sorry to cut you off, but
That's okay.
there's in Canada, only 4% of people even ask about recovery who are going into these safe injection sites. In New York, it's only 1%. What are you going to do to try to push? Why? I mean, I don't get it. I'm not for this anyway, and I'm going to fight this to the end. But I just wanted to get it on the record that you guys are in support of it. And I'm going to let you go because I don't want to say things that are not nice, and I'm at that point, so I'm going to try to hold myself. But this is definitely not over.
I appreciate that, and I just want to say we will not go around council people. We will be consulting if this were to occur or be a legal possibility. And I appreciate. Absolutely, we would talk to the council people about their.
Well, it wasn't a
advice
legal
about talking to the
possibility
community.
until the people appealed it. We did fight this. We did win in the Third Circuit Court, and now not you, but the people who are appealing it now are appealing it on religious grounds, which is just ridiculous to me. I don't remember anywhere in the Bible, and I read it fairly often, where it says in the commandments or anything like that, thou shalt shoot up. For me, it's just saying that we're giving up. We don't have any idea how to handle this. And if that's the case, then maybe we need to get new people that can actually have other ideas on how to get these people into recovery. That's all I got to say. Thank you, Council President.
Thank you, Councilman.
Thank you, Councilman. Dr. Bowen, thank you for your patience. Next up, Councilman Jones.
Thank you, Mr. President. And I look forward to Member Harity, Member Lozada's, and Member Squilla's deep dive into a Kensington solution. I hear his passion about the current status quo and understand that he really wants some movement, some thought given to this, and more importantly, some action taken by it. So, folks, if you feel as though he is passionate, it's because he is. This is a lived experience for him. This is a neighborhood in which he lives, and so he deals with it every day. So I just want to, on his behalf, say that he is showing a great amount of restraint in kind of settling that passion. So I get why he is a bit unnerved about the status quo. My questions are slightly different, and it's on behavioral health. I have not once, but several times, had constituents come to my office and say, Councilman, I don't know what to do with my child. Councilman, they are in crisis. Councilman, I am in fear of my child. Councilman, my child has put hands on me. And in that process, they have attempted to what is called, and you can give me a definition of it, 302 them. And in that process, on both ends of it, were a little bit frustrated. They were frustrated by what are the levels and standards by which someone who is exhibiting crisis and can be 302. And as important, if they present a danger to themselves or others, what is that level of of expectation and engagement. And then on the other end, where do they go? How are they treated? And when they're released, what is the process for their release and notification of the people that are living in fear? And it's a hard thing to deal with, loving something you fear, whether it's their child or their spouse. I can't imagine how that impacts their well-being. So if you could give me a sense of what a 302 is, what the processes are, and who and how are people engaged to deal with that matter.
So thank you for the question, Council Member. So much distress to be challenged with a situation like that for everybody, for the person who's in distress, child particularly, for an adult as well in behavioral health crisis, for the family who's also impacted so strongly by these crises. The 302 process is an involuntary commitment process. It's a process that has somebody committed to a behavioral health hospital setting against their will. It's a legal decision that's made with the input by the psychiatrist, but it has certain criteria that have to be abided by. And there are folks who do get frustrated with the 302 situation, because when someone is brought in for a 302, adult or child, they are evaluated. And they're evaluated, and it might be that the evaluation does not meet the criteria for commitment, or the individual's current situation has calmed so much that they don't meet the criteria. What is supposed to happen is, a non-committed but still active, plan to engage the person in treatment, and the family as well in treatment should happen at that point. Keep in mind that we are trying to make it as easy as people to know what to do in that moment when they're not sure what to do. Calling counsel is great because you're all really helpful, but you can also call the Philadelphia crisis line, like call 988 if you're in that kind of distress. It is actually the Philadelphia crisis line that can help you also figure out whether that's a 302 scenario. And also, if you have questions, but it's not necessarily at that crisis point, also we're trying to make it easy for people to know what to do when they're in that situation. So it's it's 888-545-2600. But that's when you're in the middle of it and you go, I don't know what to do. My kid is X, Y, and Z, or I don't know what to do. My loved one or family member is X, Y, Z. You can call and ask questions and get all those answers. The crisis line is when they're in distress. Now, to some of the specifics of your question about criteria and all, I'm going to ask Dr. Shoyinka, our Chief Medical Officer, to just chime in for a moment to clarify some of my more general statements that I made. Dr. Shoyinka?
Thank you.
You're on mute.
Good afternoon, council members, Dr. Bowen. Pleased to be here with you. Let me say, first of all, that
state your name for the record for the stenographer.
Pardon me. My name is Dr. Susumolu Shoyinka. I'm the Chief Medical Officer for DBHIDS.
Thank you.
Let me lead in by saying Dr. Bowen's recommendation is the one that is entirely accurate. Because of the complexity of these situations and the many factors involved, it's best to lead in by calling the Philadelphia crisis line. Not only will that individual or the family member have access to trained counselors who can help to de-escalate the situation in the moment, and or dispatch a mobile team to the venue, to the site, they can do either of those things, is what I meant to say. Now, the criteria for a 302 really rests on the idea of imminent danger, which could include inability to care for self. The individual, the one additional consideration is that often there's a 302s are served by the Philadelphia Police Department here in the city of Philadelphia, and they have a period of time to serve that 302. And so that adds to the complexity of the situation, meaning that sometimes by the time the 302 is served or arrives, that person is identified and found, the crisis is over, and they no longer need to be placed under an involuntary commitment order for treatment. And so again, I'll circle that back to the earlier comment that was made by the commissioner. In those situations, it's probably best to call 988 or the Philadelphia Crisis Line first.
So I'm going to yield the mic, but my last comment on this, and hopefully there'll be an answer, is how long is that evaluation process and what does it entail? And then when the crisis seemingly subsides, because, people get well, they get worse, they change. It's not a static situation. When violence occurs, and let's say they get a protection order, before they are released, shouldn't there be at least some discussion on where are you going? How are you going to get there? Who are you going to live with? Because you can't live with the person that now has a protection order. Is there any discussion in that? And is there notification that the individual that was 302 is now released?
Dr. Bowen, would you like me to answer that?
You can answer that, and then I'll just follow up because I have some thoughts as well.
Okay, so I'll ask you to repeat your first question, sir, but let me answer your second question. The short answer to whether or not families should be notified is yes, they should be. The wrinkle there is that in our system, the HIPAA regulations have often been interpreted to mean that families or other persons cannot be contacted, with that information. So it's unfortunately the case that many individuals get released and just show up on the doorstep of their family, so to speak. And when there's a concern about danger, or to the other persons, there are standards in the mental health field that require that those individuals be contacted directly if the parameters are met. So I know that's a bit more complex than what you asked, but
no, I'll follow up from that if you're okay, Dr. Schenker, just because it gave me a thought. So the way it's supposed to work is that the treatment teams do support the families, especially you started the conversation around a child. So the family obviously would be involved in the treatment. If it's a grown child or an adult, that comes the kind of things that Dr. Shoryenko was talking about. But we have a whole array of supports for kids and parents. We have a really robust continuum. It doesn't necessarily have to rise to the level of commitment at a hospital for there to be intensive treatment provided to family, to parents, to individuals. We have caregiver support. We have family voices. Families have the ability to do a whole array of. We have urgent care centers on the children's side, which is another wonderful option if it hasn't risen to a crisis, but it's not just a regular day. You may want to bring your child to an urgent care center. So there's actually a really robust continuum of options to support a family, a child, who are struggling with the kinds of things you're talking about, which are real behavioral manifestations that would probably benefit tremendously from an intervention. But again, if you're in a crisis, you can have access to the full continuum by calling 988, having them make the assessment, figuring out if it's not commitment level. That doesn't mean it's not all of these other levels that are available to intervene. And if it's not at that level, but you still have a million questions about what am I supposed to do in a situation like that, if you do call 888-545-2600, they can talk with you about the supports for families, the supports for the individual, and that whole array is one of the things about Philadelphia's behavioral health system that we need to really continue to elevate for people, because there is so much more than people think. And that's why we're trying to make it as easy as possible to get access into the system and then have all of these options available depending on what your situation is.
I'm going to pass the mic, but I would love to offer particularly city council staff with some orientation about those options, those list of things that can be done, because there is nothing more, how do I say, nothing more catching you flat-footed.
Distressing.
Yeah,
upsetting.
That's a better word.
Painful.
Even for elected officials. When someone says, my child is out of control, help me. And again, those numbers are important, and those processes to understand are important. And I think there is that kind of training, exposure needed not only to those people in distress, but the families that are placed in crisis because of it.
I agree. And the whole point of making 988 so easy, so accessible for anyone, if you or a family member are in a crisis, to call. You're going to get a bunch of really helpful people who are going to answer that phone and really provide you with those kinds of support. So we really, really encourage people to use 988. We've built out a much better behavioral health crisis system than existed a couple of years ago. And so we really do want people to know that it's there and available. And I want to hark back to one of your comments, which was a bit about social determinants. And where is that in this mix? We have built it and embedded it into this. So for 988 and for PCL line and for mobile crisis response, they will be checking on those things as well. We also have a lot of materials we've distributed to City Council, but we're going to check and make sure that everybody has all of our up-to-date information, because that's good to distribute for people to know. When they're not in a crisis, you still need to know so that you're not struggling at that moment with the, I don't know what to do.
Thank you so much. Thank you, Mr. President.
Thank you, Councilman. Chair recognizes Councilwoman Lozada. Okay. Councilwoman? Here.
I'm sorry, I'm good. I heard some of the responses in the conversation. Thank you.
Good, Councilwoman? Okay.
Yeah, thank you.
I think Councilwoman Gautier, you wanted to come back for a second round? Another round of questions?
Yes, I have questions for OHS. Is that appropriate now?
Oh, you were for OHS now. So we're good? Okay. Dr. Bowen, get out of here while you can.
Thank you all. Appreciate you all very much.
Thank you for your work.
Bye, Dr. Bowen.
Appreciate it. Thank you so much. Next up, we had the Department of Public Health. And up to testify is Dr. Bettego, our partner in dealing with COVID.
Yeah. Okay, if I go ahead and start.
Thank you. Yes, Doctor, please, you can proceed.
Great, thank you. So good afternoon, President Clark and members of City Council. I'm Dr. Cheryl Bettigal, Health Commissioner. Joining me today are Deputy Commissioners Dr. Frank Franklin and Dr. Paula Raval-Nelson and Ryan Taylor, Chief Operating Officer. I'm pleased to provide testimony on the Department of Public Health's fiscal year 2024 operating budget. The fiscal year 24 budget will continue to support our mission to protect and promote the health of all Philadelphians and to provide a safety net for people who are disproportionately impacted by societal factors that limit their access to health care and other resources necessary for optimal health. You have my full written testimony, so I'll summarize. The proposed fiscal year 2024 general fund budget totals $143,736,320, a decrease of $16,848,542 from fiscal year 2023 estimated obligation levels. This decrease is due to the closure of the Philadelphia Nursing Home, PNH. Funding for non-PNH functions increases, allowing critical public health programs to grow. The department is requesting 1,081 budgeted positions for fiscal 24, an increase of 13 positions over fiscal 23. The increase is attributed to hiring additional staff for the medical examiner's office and restoring the numbers of our urban health policy fellows to 2 per year. I do want to note that several of our contracts with minority-owned firms are still in the conformance process, making our OEO participation numbers appear much lower than they are. We are committed to continuing to diversify our contracts, and particularly to contracting with minority and women-owned businesses located in Philadelphia whenever possible. As we emerge from the pandemic, the Health Department has worked to strengthen and expand other important areas of our public health work, while continuing to provide pandemic-related services over the past year. We've put together a new strategic plan focusing on both equity-focused work to address the major causes of death and disability in the city, and the need to address workforce recruitment and retention through initiatives that focus on well-being, professional development, and pipeline and advancement opportunities to build a diverse staff and fill vacancies. The Mayor's fiscal 24 proposed budget includes increased funding for a range of important public health priorities, including infant and maternal mortality, gun violence and overdose prevention, and the building of 2 desperately needed health centers in the lower Northeast. The new health centers would fill a void that has prevented tens of thousands of Philadelphians in an increasingly diverse area of our city from receiving timely, potentially life-saving care. As Council considers this budget, I ask you to take a few minutes to remember all of those who've lost their lives or seen them altered forever because of that void, but also to celebrate that we come here together with a path forward to change the future for so many residents who will need these services in the coming years. This is truly a historic moment. I also want to take this opportunity to remember Dr. Thomas Story, who led our city health centers for many years and who believed deeply in the mission of the health centers to be a place where high quality care is delivered with compassion, dedication, and in the language of each patient. Tom would have been so incredibly happy to see these projects finally move forward after years and years of effort. Key highlights from the past year include the launch of the Philly Joy Bank, our new basic income support pilot program for pregnant people in the areas of our city with the highest rates of very low birth weight, developed through our Community Action Network, which is a multi-sector collective impact effort aimed to reduce racial disparities in infant mortality. Our doula program has served more than 100 pregnant people with substance use disorder, helping to keep them safe during pregnancy and the postpartum period. Our free Pacify telelactation app has served over 5,000 new families over its first year. And our Safe Sleep program has distributed more than 1,100 free pack and play cribs as part of our efforts to reduce sudden unexplained infant death syndrome. Our city health centers renewed their patient-centered medical home recognition with behavioral health services distinction for all sites in June of 2022, a mark of clinical excellence, and completed more than 315,000 patient visits in fiscal 22. PDPH staff worked with OIT to create an online primary care finder tool available at phila.gov/primary care to help Philadelphians access free and low-cost primary care services. Our COVID containment staff distributed more than 350,000 over-the-counter COVID-19 tests to community groups and individuals to help ensure access to testing. And our homeless outreach program has held 107 vaccine clinics and given nearly 3,000 doses of vaccines, including shots against COVID-19, Mpox, and hepatitis A. Our public health laboratory used grant funding to create a whole gene sequencing laboratory, enabling us to detect new COVID-19 variants and opening the possibility of sequencing in the future for other viruses. Environmental health services created educational videos about regulatory compliance for childcare and food establishments and worked with L&I to fully implement the lead certification law for all rental units. Our Division of Substance Use Prevention and Harm Reduction distributed more than 60,000 doses of naloxone and trained more than 2,300 people in overdose recognition and naloxone administration. We continue to work to recruit and retain a talented, diverse staff of public health professionals. While vacancies continue to be a challenge, we have succeeded in obtaining a workforce grant from the Centers for Disease Control to help strengthen our recruitment and retention efforts and to develop programs to build workplace well-being based on a model created by the Surgeon General. I would be remiss if I did not take this moment to thank and to celebrate the tremendous hard work, dedication, and expertise of our public health staff, who have worked so very hard to keep our city safe and healthy in unbelievably difficult conditions these past few years. They are truly public health heroes. I thank you, Council President and members of the Council, for your continuing support of public health in Philadelphia, and I'll be happy to answer any questions.
Thank you, Commissioner. Commissioner, I had a question about the nursing home. I saw in your budget testimony you talked about a decrease in terms of funding directly related to the nursing home closing. There's a interesting level of interest in the nursing home from all kinds of different people, developers, some public service agencies. So let me understand, we've had a multi-year contract because I believe the building is owned by the state. Am I correct?
Yeah, so it's owned by the state. We rent it for $1, and we have a 50-year lease through 2026.
Okay. So 2026 is the expiration?
Is the expiration. I mean, presumably there
okay.
might be some ability to renew, but we're no longer running a nursing home there. So we need to work this out with the state.
Okay. So if there is an agreement, because I know that there are multiple people aggressively marketing the site, the ability for the city to terminate the agreement is based on the state authorization? How does that work? Say, for instance, I know of a couple of people, they want to do various things. It'll be interesting community meetings over there. How does that work? Do we say, okay, we're out of the contractual relationship if they want to sell it tomorrow?
So we would have to work it out with the state. The Department of Public Properties would need to be involved. So, in terms of, we're not running a nursing home there, but in terms of how the rest of that gets worked out, I think DPP, and I may pull Eva into this for just a second, if you don't mind.
Yeah, I think we
still Mary.
I think we still have employees in there. I see city cars sitting in there from time to time.
There are some other uses going on there right now, and the city is looking until 2026 at some potential uses on an emergency or whatever basis. But we've indicated to the state that, presuming a compatible other user who would allow us to continue to use it from time to time while they were planning the redevelopment, we would be okay with its transfer. So we've communicated directly with the Secretary of GSA at the state about that.
Okay. All right. So in terms of the closure, what alternative locations have we used for the clientele, the patients that were in the nursing home? I know a lot of people there for a lot of years. How did we transition them to other locations?
So we did a very intensive process, including bringing in a consultant to help support, to make sure that families were offered a choice of locations and were able to find something that met their and their loved ones' needs. So, I mean, that we did a lengthy closure. So we started that process in June, extended through the 28th of October, and were able to find places for all the residents, except for a few who transitioned to the community at their own wish.
Okay, so we're good on that. Okay. How are we doing on generally? We notice how we don't even ask about COVID anymore. It's almost like it doesn't exist.
I'm so used to having
actually,
no conversation.
what happens with May? What's the date when the federal?
When the emergency ends? My biggest worry when the emergency ends is about Medicaid. I think that's our greatest vulnerability. I mean, in Philly, but also nationally. We have a lot of people in Philadelphia who are covered on Medicaid. We have a lot of people who don't necessarily read easily. We're trying our best to do an all hands on deck communication to people about what they need to do to update their information in Compass, what they need to do if they do accidentally get terminated, to provide all sorts of support. The new administration in Harrisburg is working very hard under Acting Secretary Arkush to support that effort as well. There's still a worry that people are going to lose their coverage. And, I think we're going to be in a scramble for the next year. It's just been, I think we've had a chance to see a little window into what it might be like to have not universal coverage, because we never got all the way there, but to have better coverage. And we want to keep that as much as possible. But I'm much more worried about that. With COVID, we have, at least for now, a supply of vaccines, supply of medications. Like we will do what we can there. That will eventually be something we'll be worrying about in terms of supplies, but more immediately it's Medicaid.
Right. Yeah, that's when all of the COVID/American Recovery Plan money runs out. We all have to figure out what we have to do across the board. I know we have some deadlines looming sooner than later. I guess you all are internally in the city of Philadelphia having discussions about some backstops or what we could potentially do locally or with other opportunities from other federal, state government.
Yeah, certainly for Medicaid, we're trying to do as much outreach as we can, including working with Philly Counts and our community health worker program there, lots of other partners to try to get information to people. Internally, we have a lot of staff who are funded on COVID grant dollars. We also have a lot of vacancies. So a piece of the work of our workforce grant through CDC is to try to matchmake, to what extent we're able to move people who are hired on COVID into positions that are open that they want, that are our civil service positions. I think that would be ideal.
Okay. All right. Okay. Well, thank you, Doc. Chair recognizes Councilwoman Lozada, I think, had a comment, a question. Councilwoman?
Yes. Question and comment. First, I'd like to thank Dr. Bettigal for all of the work that she's done, not only in support of me, but in support of community-based organizations like Esperanza, and providing access to community residents across the city, but also and very specifically here in the 7th Council District. I am eternally grateful, and I know that many of my community residents are and don't have access to you, right, to be able to tell you how grateful they are of you and all of your team that consistently showed up and provided the necessary access to us as a community. My question is, many people walk around and they don't think COVID exists anymore, right? There's not a COVID scare. Can you tell us where we are as it relates to COVID? I still have staff members that report testing COVID positive and are out for a week or more. We have community residents who are consistently asking for tests. Where are we? Should we continue to be concerned? Are there still fatalities that we don't hear about? Where are we as a city?
So things are better than they've been since, I would say, last May. We're still seeing significant levels of COVID passed in the city. It's still out there. It's probably going to be out there for the next several years. We're still seeing some hospitalizations, but many fewer than we were even 2 or 3 months back. So things are very slowly getting better. That doesn't mean we're out of the woods and people should forget all caution. So, I would still recommend that people wear a mask if they're in a crowded public place, if they're on the bus, if they're going to a mall, somewhere where the yield for being unmasked is not as high. And what I mean by that is if you're having dinner with friends and family, you don't want to wear a mask. If you're on the bus, you probably don't care that much. So then put the mask on there. And that gives you at least lower risk. We do want to make sure that people who are high risk have gotten their boosters, and that continues to be important, and that they remember that there are medications out there if they do get COVID that need to be taken fairly soon after infection to be effective, but that can very effectively prevent hospitalization and death. And the other thing is, if you're going to be visiting with somebody who is vulnerable, either because they're elderly or they're immunosuppressed, they're on cancer therapy, do a test. We do have tests. We have a lot of tests. Our community distribution program is still active. If any of the council members' offices would like information on that, please let me know. We're happy to get that to you. We have, I think, 250,000 tests in stock, and we can get more. So we want to make sure that anyone in the city who needs access to those tests can get it. Insurers are still covering tests through May 11th, and I would encourage people to access them through their insurance if they have coverage, and kind of get a little stockpile so you have a few on hand in case you need them. So, things are better. I think that the need for people to socialize and to be with each other is very real as well. So I'm not telling people not to be around other people, but just, some level of caution is still in order.
Awesome. Thank you so much for that update. I also had an opportunity when I first arrived in council to visit the morgue. And I met with some of the employees there who talked about the stresses that they experienced through COVID and having to be frontline workers and having to show up every day. And with the increase of violence and fatalities as a result of violence, there's more work. But the number of staffing doesn't increase. And so can you tell us if in this budget you have made way, you've talked to the folks that that sometimes we don't talk about, right? We don't talk about those folks that work in the morgue and what their needs are. They talked about staffing shortages. They talked about equipment shortages. They talked about something that really I can't get over, and I think about it all the time, which is the ashes of people that are still sitting there because families couldn't afford a decent burial, or the ashes of individuals who are sitting on shelves as a result of never being claimed. What do we do? Is there a way, can we do something to be able to give those people a decent burial?
Yeah. So this is a budget that does invest in our medical examiner's office. It increases staff there, and we've already started the hiring process for those positions. And thank you, by the way, for flagging this. One of the, we have a lot of staff who have worked harder than any human being should work. And one of the effects of the increase in homicides and drug overdoses has been a huge increase in work for a medical examiner's office. We have people working overtime. We've had mandatory overtime at periods. That's just brutal on people. And then somebody leaves, and then we have more overtime. So the hiring, the additional positions have been really key. And Dr. D'Angelo, who's our new chief medical examiner, has been a good advocate for the department, for the division rather. And so those positions got approved, and the hiring some of the positions have already been hired for. People are in training, and then the others are going to be hired moving forward. They can only train a certain number at a time. In terms of the burials, that's one of the things that I also found out about when I started, that we had people who hadn't been buried. Just
they're sitting on shelf.
Yeah. So we do have money identified for that. We're also, and you'll hear from Liz Hirsch soon with Homeless Services. Liz has helped to organize this, but we are doing another homeless burial funeral event, and the health department is contributing to that as well. We want people, it's a last moment of dignity, and we should give that to people. And by the way, this is unrelated to the MEO, but I should also thank you for your tremendous partnership in helping us get people vaccinated in your neighborhood. So
Thank you, thank you. And then one last thing, one last request that I think it's a very simple request, and I hope that we can get it done for them very quickly or fairly quickly. Oftentimes when families come to identify their family members or their loved ones' remains, they come into the building that is in the same building as the police department. And so the medical examiner's office oftentimes is confused or associated with the police department building or space, and they get a lot of heat for it. And so they have asked for me to advocate for the sign on the door just to say medical examiner, Department of Public Health. Can we do that? Is that a simple, I mean, I think it's simple. I don't know how difficult that is, but can we do something like that? And should I be talking to you about this, or the Department of the what is it, Greenwald's office?
DPP, I think we were working on a sign because they had raised this as well, the MEO. We'll follow up on this, but we'll figure out. I want to make sure I understand exactly what the community members are saying, and then we'll figure it out.
They want to be able to identify the medical examiner's office as an office that is under the authority of the Department of Public Health and not associated with the Philadelphia Police Department.
Got it. Yes, I think this came up, and I think we were trying to, I mean, we have to go through DPP to do it, but I think that there is somebody working on this, but I'll double check on the status. Thank you for raising it.
Thank you.
Thank you, Councilwoman. Chair recognizes Councilman Jones.
Thank you, Mr. President. Thank you, Member Lozada, for caring about those details. That means so much to people that, you know, are doing their jobs. Commissioner, I just want to thank you. I want to thank you for all you have done and your department, your team. I take us back to 3 years ago when we were living in fear, when we were not able to truly define what COVID.
Good night, Josh. Where did it go?
Can some folks mute themselves, please?
Oh.
Can you please go on mute if you're not speaking? Thank you.
So I remember when we were looking at our mail, leaving it out for 2 days so that it would decontaminate. We were washing our produce and our items from the grocery store. I remember us not wanting to walk on the other side of the street from each other. But one of the things that I thank you for is that you led us through facts, not fear. Your department led us through with facts. As you were able to determine them, you gave that information to President Clark, to leadership, so that we could distribute it to members and get it out to the community. We dealt with health disparities by way of testing. We dealt with health disparities with you by way of shots in arms. And I remember all through that process being proud, at the federal level, it was Fauci. At the local level, it was you guys. So thank you for that. I remember in my district when we have maybe other than O'Neill, we have the largest number of senior facilities and naturally occurring retirement communities such as high-rise apartments that have a lot of seniors in them. And we had a weekly roundtable meeting and started to look at the needs of them, and as well as institutions like Belmont Behavioral Health, PCOM got involved, and we all realized that we had a shortage of PPEs. And the health department stepped up to the plate to give places like Simpson House and Inglis House those kind of PPEs, not just for doctors, but for the people changing the bedpans. And I just can't tell you how thankful we in the 4th District are for you. I remember you and your department doing and developing the aardvark, which is probably parked now. But I remember that being a beacon of hope rolling up to rec centers and testing people. Long lines of people uncertain about whether or not they had COVID, and the feeling of relief that was felt when they left and realized that it was negative. So y'all ain't perfect.
We know.
Neither are we. But I couldn't think of a better department to go through that uncertainty with than the health department. So thank you. That's all I got to say.
Thank you very much.
Mr. President.
Thank you, Councilman.
Thank you.
Commissioner, I don't see any other questions for this witness. Make sure. All right. So thank you. Thank you for your service. Thank you for your team. Thank you for all you do for the citizens of the city of Philadelphia and helping us keep us safe. Really appreciate it. Thank you.
Thank you for the partnership.
And next up, we will have our last department, the Office of Homeless Services. And we will have Ms. Liz Hirsch. Hirsch, are you ready?
Ready, thank you.
All right, let's rock it.
Good afternoon, Council President Clark and members of City Council. I'm Liz Hirsch. I'm the director of the city's Office of Homeless Services. Joining me today are David Holloman, Chief of Staff, Indira I. Potter, who's Deputy Chief of Staff, Peter Curran, Deputy Director for Finance, Contracts, and Asset Management, Mary Beth Gonzalez, Deputy Director for Policy Planning and Performance, and Roberta Cancelier, Deputy Director for Housing Services. You all have my full testimony, so I will be brief. I also sent you each a copy of our annual report, which gives highlights of numbers, dollars spent, stories from fiscal year 2022. So you have that in your inbox if you would want some additional information. First of all, I want to thank all of you in council for your support of the Office of Homeless Services. You have truly been partners to the Office of Homeless Services, invested in us, believed in us, and that has made a difference. And we have seen in many cities across the country where homelessness has been criminalized, and that has not happened in Philadelphia. We are truly a place where we exercise compassion and love. We're still firm in having the rules of civility, but we understand that nobody wants to be homeless and that we need a shelter system because shelters saved lives. But what the real solution to homelessness is deeply affordable housing. As a result of these investments in our community, as operationalized through our more than 70 not-for-profit social services and homeless service providers, we have actually seen the number of people experiencing homelessness go down. We've seen a reduction in 22% of people who are unsheltered and 42% of families. And this is based on our annual point-in-time count. Nonetheless, still too many people do touch the homeless system and experience periods of homelessness or experience chronic homelessness and are on the street. So while we appreciate and value the affordable housing, the deeply affordable housing that we've been able to provide for people, we also recognize that there is still so much work to be done. As you're well aware, the mission of the Office of Homeless Services is to make homelessness rare, brief, and non-recurring in Philadelphia. I want to just briefly highlight some of the kinds of innovative programs that we have pioneered through our network of homeless service providers, and that we will invest in going forward in the coming year with the additional dollars that are allocated to us if they are approved. Shared housing. We love shared housing. Most of us live with roommates at one point or another in our lives. And yet, if people get a federal subsidy like a housing choice voucher, public housing, they are prohibited from having a roommate living with an unrelated adult. We don't think that that's a great idea. We think that people ought to be able to have roommates. So we've been working in partnership with the Housing Authority to rehab long vacant scattered site units for roommates to live together, as well as for large families, and those units are permanently affordable. We're providing housing for college students who would otherwise be homeless. The city has made such a large investment in community college and Cato scholars, but without assistance, we have still so many young people, young adults, who are unable to attend college and take advantage of the life-changing opportunity that higher education provides. And so we're piloting housing programs for young adults experiencing homelessness who are in college. It's become clear to us with the graying of the homeless population that more and more people experiencing homelessness need assistance with activities of daily living. And while we accepted over 1,100 referrals from hospitals last year, we still do see people who are homeless and need help with going to the bathroom, getting in and out of a wheelchair, managing their medication. They don't need hospitalization, but they do need help with those basic activities. And so we are piloting with the Public Health Management Corporation a medical respite that offers additional beds where people can get assistance with those ADLs. Where we have piloted for several years and are expanding shallow rent. Many of the people who experience homelessness have a very limited income of maybe $800 or $900 a month. Imagine trying to find an apartment on that amount of money. It's just not possible without a subsidy. Our shallow rent program has enabled them to pay a fixed low rent of $200, work with landlords. We provide a backstop to the landlord, reduce turnover, and mitigate their risk. And we've seen that program be tremendously successful in preventing the cycling through of homelessness among people who have disabilities. And our PEACE program, which is helping people who are fragile, elderly, get into a situation that's least restrictive for them, where their needs can be met. And we're also really excited by two brand new initiatives. One is our Landlord Gateway. And through Ebony Williams, our Director of Landlord Relations, Landlord Affairs, won a competitive grant to establish a one-stop shop that has brought together 16 city and public agencies so that private rental market owners can take advantage of city programs. Right now, if you go to the city's website as a property owner and you want to do something to help with the affordable housing crisis or homelessness, it's very hard to navigate. But once the Landlord Gateway is launched, there will be not just only a one-stop shop, but it will help landlords, it will help have navigational support to access a wide range of programs that are available so that they can be part of the solution. And finally, we're very excited that we have our youth demonstration, homelessness demonstration project. This is an $8.8 million grant from the federal government that we won competitively. We will be submitting our coordinated community plan in just a few weeks. This entire process has been led by youth and young adults. It's just amazing when given the opportunity for leadership and we're paying them for their participation, the solutions that they have come up with to help not just themselves, but others in the community. Once our plan is approved, then we will be putting those funds on the street, putting out an RFP and putting that money out there to try and reduce homelessness among youth and young adults. So I'll stop there and entertain any questions that you may have. Thank you very much.
Thank you. Thank you for your testimony. I had a couple questions. Maybe a little interesting. So I remember a couple of years ago, actually, when we had a number of current mayoral candidates in this body. One in particular, they were talking about tiny houses, and the tiny house conversation, I think, was in conjunction with some ability to solve homelessness. And I actually think it was a request for proposal, or there was some sites identified. Did that go anywhere? Or do you recall that conversation about the tiny houses?
Yes, yes.
Whatever happened?
Well, we're experiencing how challenging it is to try something new, but we are persevering. Yes, absolutely moving forward. There's 2 tiny house projects in process. The one that I think we will break ground this year will be for 29 10 by 12, what are basically detached bedrooms where people can live who are exiting homelessness. It'll be up on State Road. It will have a shared kitchen and bathrooms. Through that RFP process that you rightly recollect, we selected Sanctuary Village. They have raised money, significant money, to put they'll be basically prefab units, and we are working out laying the groundwork. We need sidewalks and electric, and they'll be on these sort of giant rollers. So it's a temporary project. We don't have a long-term plan because it is new. Councilmember Driscoll has been extremely supportive. The other will be in Councilmember Gautier's district. That'll be 30 little units that are slightly bigger. I believe they're 500 to 600 square feet. And they've been also are working through the competitive process under the auspices of planning and development. And that will be longer term housing for, I believe, also prioritizing older adults. So yes, they're moving forward, but we had to wait for the International Building Code to change. There's all kinds of interesting zoning and construction challenges that we're working through, but we're moving forward, and we're optimistic. It's going to happen.
Okay, won't be surprised if you see it pop up in the Merrill commercial, right? And
yeah,
tiny house is a solution, right? All right. Another interesting thing that it's reality based, but it's not discussed. And I don't know how you would be involved. So in our neighborhoods, and some of these neighborhoods, we have significant challenges with some of the youth that are involved in negative activity, be it drugs or some other aspects. My understanding that there's a lot of these young people that are actually homeless. I know of a number of locations in my council district, and I'm assuming in Councilman Jones' district and others, where literally, as an example, on Susquehanna Avenue over in Strawberry Mansion, there was an abandoned house. The house was, wasn't open, it was boarded up, and the young folks to say, you know what, we're going to take over the house. And they literally lived there because they had like nowhere else to live. They couldn't live with the family members or whatever circumstances happened to cause them to be homeless. Are you aware of the homeless nature of those type of individuals? Has that ever been brought to your attention? Because I see we're looking at, different types of homelessness, and in your presentation, you talk about homelessness for different categories of individuals.
Yes, we are painfully aware of this situation. It's heartbreaking. Because when you're young, you're hopeful, you're resilient, you're still growing, and that's really the moment to interrupt that cycle of homelessness. We do have a youth homeless outreach team that comes out of Valley Youth House. It's called Synergy. And so if you're aware of young people who are homeless, you can call the regular homeless hotline, or I can get the number for Synergy for you. And they do have a number of young people who themselves have experienced homelessness who go out. One of the differences between young adults and older adults in experiencing homelessness is the hiding and the shame. And so what we hear from the young adults in our young adult leadership committee who are driving the planning process that I mentioned earlier is that they pretend and they try to pass. So they may be going to school every day, but not telling anybody what their circumstances are and just trying to get by. And so one of the reasons we're so excited about this YHDP grant is that it will make a dent. There will be more housing and more emergency housing and more services for young people. The other thing about the young adults is there's a couple things. One is they want adults to take care of them. They tell us, we want you to ask us if we're okay. We want you to notice if we're not okay, and we want you to reach out. They don't want to have to be the adults who ask for help all the time. They want us to still take care of them, which, as you know, if you have young adult children, is a tricky business, but that's what they tell us. So we want to have, the other thing is they need more. They need more help. They need that long runway to get education, to get money, to figure out if they have a behavioral health situation, to reconcile with family. And so we're looking at more robust kinds of services, and they want to work. They want to have family sustaining jobs. And so that's the way our community coordinated plan is evolving, is to try and do a better job of giving them more of what they want so that they don't have to live in an abandoned house. So they have a lifeline and a better prospect for a better future.
All right. So this population, and I'm glad that you know about it, not glad that it exists, but that you are aware of the challenge in this particular category of individuals. And the reality is I suspect that they will not entertain the traditional outreach or trying to get information off the traditional sources. So have you ever given any thought, since you do understand it is an issue, to working with the individuals that we provide these grants to? We have a number of individuals that are out there, and that's kind of where I got it from, that are reaching out and interacting with the young people that have challenges in life, dealing with violence prevention, that they can be armed with the information that, as they talk to them and find out that these people don't have anywhere to live, right? Do you have any interaction, or can you have some interaction with those groups that are out there in the street on a consistent basis?
Absolutely. Our coordinated community plan has engaged the mayor's office of children and families. We are working with all of the violence prevention groups as well to try and weave that all together. But if any of you know of groups or individuals who may not know about our services, we would love to be connected with them so that we can do a better job of weaving this all together and having the helping hand.
So, Council President, good afternoon, Council President. So one of the issues that you talked about, and
just say your name for the record.
Good afternoon, David Holloman, Chief of Staff for the Office of Homeless Services. So one of the issues that we want to work with is the group like Mel Wells out of One Day at a Time, like those neighborhoods. Like, I'm a native of North Philly, so you have kids that are coming in these houses that may have been of their grandmom, and having groups of kids that come in there. Back in the day, we used to call them abandonmenium, where kids would come into. It is important that we get trusted messengers like Nomo, like Mel Wells, who got the Bike BMX group. Part of that initiative, I see Beth Gonzalez on here, who has been really tremendous in helping coordinate the drafting plan, was to get out to a diverse group of people who are in those neighborhoods to do that outreach, because they're not going to come to your traditional legacy providers that they don't trust, they don't see. So it's going to be very important to do that outreach with community groups like NOMO, like Man Up PA with Solomon and them who's in those schools, and like Mel and them who does those BMX, to really identify where they at deep into those communities and how we get outreach to them. And they have to be someone that looks like them, that's almost in that peer group too.
Great.
Yeah.
Okay.
One thing I'd like to add, Beth Gonzalez, Deputy Director at OHS. In addition to that, we're also working with those organizations with the School District of Philadelphia with their COVID funds, the ESSER funds. And we have somebody who's been hired and is going to be embedded in OHS for 2 years and working with the school district so we can look at anybody who's potentially truant or not connected to the community and the schools and also experiencing homelessness or at risk, to make sure we connect them to those organizations to then make sure they get the supports they need as well.
Great. Okay. It's good to hear. I'm glad I asked that question. All right. Well, thank you. Chair recognizes Councilman Jones.
Thank you, Mr. President. I'm glad you asked that question too, because it is the one I want to expand upon. A credible messenger that is a professional in the hierarchy of DHS and CUAs mentioned to me that there is a office or facility that young people actually get to stay in. It is an office where they receive some service. They can get a meal there, they can get showers, but there is no ability to force them to stay, so they come and go as they please. I was told that this particular population, not trying to stereotype anybody, but they are of a transient homeless status and were a major part of what we saw downtown with those 200 young people on Market Street. Further, I was told that that population may have come into contact not only with DHS, but with the law, some of them, not necessarily in a convicted way, but are also a part of influencers of other young people that may not be homeless, but may not want to follow guidelines of curfews and things like that. So they, I hear, leave out of that facility and then go down to Delaware Avenue and engage in all kinds of things. I'll leave it at that. But are you familiar with them, and do you intervene with them?
So I think
That is not an OHS facility, so we do coordinate quite closely with the Department of Human Services with young people who are experiencing homelessness and who are known to the DHS system, but we don't run that program specifically. That would be a DHS facility. So Dave, were you going to add something to that?
Yeah, the only thing I was going to say about that, like, we can't speak to say who those kids were that came downtown last week in Center City to interfere in that. There are facilities that, like truancy programs, where kids get brought to for after school or missing school that goes down there. So we can't speak to an exact of who those kids were identified with. I think one of the things that we have to be mindful of is that social media, how that drives trends and where it drives kids too. I think one of the things that we're doing with our youth development, working with our youth group, is really trying to understand them from a social media perspective. How do we engage them? How do we communicate with them? And just to inform them about the programs that we do have that are positive that they can get involved in. But we can't really, I think, like Liz indicated, we can't really speak to saying those kids were part of our system or not.
No, I'm not. So I was particular in my choice of words, not to say they were all anyone's kids. They could be my grandkids. The point is that there is a central point of folk that are in that particular office space that are homeless. That I would hope that your department could work with their department to solve that. And they've learned how to adapt to their situation, get the services, and then leave out and wind up a part of folk that may have homes and young people, but they are also a group that needs our services. So what I'm encouraging us to do is, if we know where they are, then maybe we can move those services to them. And you're not going to convince everybody, but you may convince some of them to seek out those services, because it is frightening for me to think of them in that vulnerable situation. Many of them wind up being exploited. I'll put it to you that way. And
you're absolutely right.
Yeah. We're hoping through the YHDP, because the youth are driving the decisions, they're driving program design, they're driving the housing projects, that we'll be able to engage those folks and based on what their needs are. And we have an evaluation arm to those project designs as well. So they'll be part of that process as well. So we're really hoping that not only will this bring in potentially up to like 175 new units for youth within our community, but then also they can actually design what that is so that we can engage them and bring them in.
So my final question, I'm going to shift from young people to, I didn't hear in your presentation, is the census of homeless in Philadelphia going up, down, or flatlined?
It's been going down.
To what degree?
It's gone down by 22%. We at the peak in, and this is according to the point in time count, but at our peak in 2018, during, really at the peak of very early on in the opioid crisis, we were at about 1,100. Unsheltered now, we're down at about just a little over 700 unsheltered.
So how does that compare? That's good news, great news, underscore, and let's make sure the stenographer has that. How do we compare to places like San Diego and San Francisco?
Our numbers, we have historically had the lowest number of people who are unsheltered among the major cities, major city being defined as over 1 million people. One of the things, even though our rents are going up, one of the great predictors of higher rates of homelessness, other than really nice weather like San Diego has, is high rents. And because our rents are still, we're not in the extremely high category like LA, San Francisco, Seattle, Portland, our numbers have stayed down it's still too many. I never want to make it seem like we're not taking a victory lap here. We still have too many people, especially Black and brown people, who are experiencing homelessness. But given the robustness of our service system, the investment of the city in the real solutions, that is deeply affordable long-term care, long-term housing, the kinds of homeless outreach we do, the partnership with the Department of Behavioral Health and Intellectual Disabilities, with the Housing Authority, our numbers are, when the rest of the country was trending up, we were trending down. So I would say we know what works here. And I'm not just talking about the Office of Homeless Services, but the city as a whole, city council, the administration, and we have made smart strategic investments, and they have made a huge difference and are continuing every day to make a huge difference in the lives of many, many Philadelphians. And, that's why we come to work every day.
Well, Liz, I remember your first day, and you've come a long way since then. And when you start talking about 22% reductions in homelessness, that's a job well done. And thank you and your team.
Thank you,
President.
Thank you, Council. We do not have any additional questions from you at this time, but as always, please be prepared for a callback during this interesting time, also known as the FY2024 budget process. I want to thank you and continue to do the work you do to help those most challenged citizens in the city of Philadelphia. Without the support of many, particularly government, there would be no hands out for those individuals to give them a hands up. So thank you again for your testimony.
Thank you.
There being no additional questions from members of the committee, this committee will stand in recess until Wednesday, April 12th at 10 a.m., at which time we will reconvene in a remote manner using Microsoft Teams. Thank you all very much. Please be safe.